Good morning. Come on to the front, please. So we're going to talk a little bit today about diastolic dysfunction and diastolic heart failure. I have no disclosures. So we'll start out with some questions that should be a little bit thought-provoking. The first question is, about half of all heart failure patients have normal left ventricle ejection fraction. A, that sounds about right. B, that number's too high. C, that number's too low. Or D, don't be silly, heart failure can't be present with a normal ejection fraction. And the correct answer here in this situation is A. Question number 2. Heart failure patients with preserved ejection fraction live longer than heart failure patients with reduced ejection fraction. A, true. B, it's the other way around. C, both groups have similar longevity. Which is it? C. Good. Question number 3. All patients with systolic dysfunction have diastolic dysfunction. Is that true or false? True. It is true. Question number 4. All patients with diastolic dysfunction have diastolic heart failure. Is that true or false? False. Good. So, my first point is the heart is more than just EF. In fact, EF shmef. EF is worthless. The only reason to think about EF is whether or not you want to put a defibrillator in somebody. Okay? And it can alter the way you treat somebody as well. Figuring out what the ejection fraction is. Treatment of systolic heart failure is a little bit different than diastolic heart failure. But for most purposes, EF shmef. Okay? I will call doctors with critical results on an echo. And I'll go on and on about some very important finding. And but what's the EF? What's the EF? EF shmef. So here are two patients, patient 1 and patient 2. Which patient is more short of breath? Patient 1 or patient 2? Notice patient 1 has a normal ejection fraction of 60%. You will notice the left atrium is ginormous. Okay? And you will see the tall E wave on the mitral inflow indicates a restrictive filling pattern. Whereas here you have a patient with a dilated cardiomyopathy. The ejection fraction is 20%. The left atrium does not appear to be particularly enlarged, at least by visual guesstimation. And the mitral inflow shows EA reversal, indicative of relaxation abnormality. So, with this in mind, which patient is more short of breath? 1. Patient 1 is sicker than patient 2. Which patient has higher pulmonary pressures of these two patients I just showed you? Same two patients. Patient 1 probably has higher pulmonary pressures than patient 2. When you have impaired relaxation, your left atrial pressure may be normal or high. And we'll talk a little bit about how to differentiate that. When you have restrictive filling pattern, you almost always have high left atrial pressure. Almost always high left atrial pressure. And if you have high left atrial pressure, what's going to happen to the pulmonary pressures? They're going to be high. So patient 1 is going to have higher pulmonary pressures than patient 2. Whose prognosis is worse? The patient with an EF of 60 or the patient with an EF of 20? This is a tough one. But if you look at multiple studies, diastolic function severity, diastolic dysfunction severity is one of the most powerful predictors of survival in patients with heart failure, regardless of EF. All right? So this may not be comparing apples to apples. This is comparing apples to mangoes or something. But still, you could probably guess that the patient 1 is sicker than patient 2. The other thing to consider is left atrial size. The bigger the left atrium, the worse off the heart is. You can consider the left atrium as the hemoglobin A1C of the heart. The more poorly controlled your heart failure over time, the bigger your left atrium is going to be. All right, here's a fun one. Can I go ahead and answer the question?
So does it, post-mortem longevity, does that apply before or after an ICD is placed to prevent some cardiac death?
The question is whether or not an ICD would influence survival. It obviously would influence survival in people with systolic heart failure, but I think all comers, if you look at the size of the left atrium, that predicts overall mortality. Not necessarily the cause of mortality. The patients with systolic heart failure typically die of pump failure or arrhythmia. Patients with diastolic heart failure typically die of their comorbid medical conditions, coronary disease, stroke, etc. All right. What if these two patients went into atrial fibrillation with rapid ventricular response? What would happen to each? What would happen to this patient here, patient 2, if they lost their atrial kick, EA? We'll talk a little bit about that in a second. What if they lost that A wave? They'd feel sick. They'd feel awful. They'd feel awful. What would happen to this patient if they lost their atrial kick? They may not feel any different. In fact, they may feel better because they have a faster heart rate. All this period of diastole is wasted on just this little itty bitty A. All the action is occurring early in diastole. So a faster heart rate might actually help them symptomatically. Whereas this patient, a faster heart rate might make them, regardless of the atrial kick or not, might make them sicker. Okay? So you can diagnose someone just with history. Hey, when I have atrial fibrillation, I feel awful. I wonder if you have impaired relaxation, just with the history. Whereas the patients who don't know when they're in and out of atrial fibrillation, you can be assured that they have more advanced diastolic dysfunction.
So beta blockers and diastolic dysfunction not necessarily.
So I'll get to that in the end. The question is about beta blockers and diastolic dysfunction, and this is there's some lot of we'll talk about it. It's not a one size fits all. So point 1, EF SHMEF, okay? Point 2, diastolic dysfunction is bad. If you look at survival curves from multiple studies comparing patients with heart failure and diastolic dysfunction, in this particular study, this is a population-based study from Rochester, Minnesota. Here's survival, here is year, red is preserved ejection fraction, and black is reduced ejection fraction. You see, these curves are pretty similar over a follow-up period of about 5 years. So if you have heart failure, your ejection fraction did not predict survival. If you had heart failure, regardless of EF, your survival, whether you had systolic or diastolic heart failure, was poor, equally poor. And what's interesting is this was reproduced in another population. That same journal, that same issue of the New England Journal in 2006 showed a similar population-based study out of Canada, and it showed very similar results. Blue with preserved ejection fraction, red with reduced ejection fraction. What's interesting is that we have improved our therapies for systolic heart failure. We have defibrillators, we have beta blockers, we have ACE inhibitors, etc. The improvement in diastolic heart failure has not been as pronounced. What if you looked at everybody after a myocardial infarction and looked at their filling pattern. Look at their diastolic function. If you had a normal, impaired relaxation, pseudonormal, or restrictive filling pattern, this is survival here, and this is follow-up. If you had normal filling pattern after an MI, which would be unusual, your survival was pretty good. If you had advanced diastolic dysfunction after an MI, your survival was poor. And in between was in between. What if you grab people off the street who were asymptomatic? What if you grabbed 1,700 patients off the street? This was done in Rochester, Minnesota, who were asymptomatic, and you just did mitral inflows on them. Okay? And this was done in 2003. Maggie Redfield at Mayo did this. And here's your mortality. And here's your follow-up. The average follow-up, I think, was 3 or 4 years. And you have moderate, mild, and normal. Moderate to severe diastolic dysfunction is here. Mild diastolic dysfunction was here. And this was normal. So if you had normal diastolic dysfunction, normal diastolic function, you were immortal for 3.5 years. Okay? Whereas if you had just impaired, and this is in patients above 45, I have to say, patients who are above the age of 45. If you had just impaired relaxation, you had a 10% mortality at 5 years. Just mild diastolic dysfunction in an asymptomatic person, in an ambulatory asymptomatic patient, predicted a 10% mortality at 5 years. Now, it doesn't say what the cause of death is. It just says that it's not good. And here we have a 20 to 25% mortality in people with more advanced diastolic dysfunction. So having abnormal diastolic function is not good.
These are the patients with normal systolic function. Abnormal, like they had abnormal systolic function as well, or?
These patients had normal. The question is whether or not these patients had normal systolic function. All these patients had normal systolic function. If they had abnormal EFs, they were excluded from that study. So,
The high age was excluded also because all this dissect dysfunction just because of age and
I think all these patients were middle-aged. I have to double-check that. I think we're all above 45, but none of them were like 92 or whatever. So, it's a common problem. Notice that diastolic heart failure is only a fraction of diastolic dysfunction. And notice that systolic and diastolic heart failure have near equal sizes of the pie in terms of prevalence of heart failure. So if you see a heart failure patient, chances are it's a coin toss about whether or not their ejection fraction is normal. Point 3. The heart, the left ventricle in particular, is more than a pump. The architecture of the heart is very complicated. This is the pulmonary right ventricle, and this is the left ventricle, which I want you to focus on, aorta. And look at the layers of the myocardium. See that? Interwoven layers, crisscross fibers of the myocardium as this heart is sort of unfolded. Very important to consider how these fibers are oriented in the left ventricle. Because what this serves as a twisting and untwisting of the heart, twisting during systole and untwisting during diastole, early diastole. And both of these are energy-consuming activities. It requires energy for systole and it requires energy for early diastole, i.e. relaxation, which I wish we would rename as suction. Suction. If we think of the heart, the left ventricle, not just as a pumping forward device, but a suction into device as well, I think that would be helpful at learning and understanding diastolic function. So let's look at, I'm not giving you any mitral inflows. I just want you to look carefully at these two hearts. No Doppler, no color, just 2D. You have this heart, and you have this heart. Which heart is normal? Which heart is abnormal? And I'm going to point out some specific things. Both of these hearts have normal left ventricle ejection fractions. Would you agree? This left atrium is massive. This left atrium appears to be normal. But there's more. I want you to pay attention to this up and down motion. See that? Down, down, down. This heart has some bounce to it. See how bouncy that heart is? Okay? Look at this. No bounce. There's no bounce. This heart is not bouncy. So I want you guys, when you look at echoes moving forward, to just pay attention to the bounciness of the heart. You will notice that young, healthy hearts have a lot of bounce. And old, sick hearts have crappy bounce. This bounce is relaxation. This negative bounce is your suction of the left ventricle. The left ventricle pumps blood out the aorta, but also sucks blood out of the left atrium and pulmonary veins. Okay? This heart can't do much suction at all. We can measure this bounce. We can measure this up and down motion with tissue Doppler. Tissue Doppler is the velocity of the tissue moving down, and we can measure it here. Okay? This is the velocity of, in this situation, the lateral mitral annulus. The deeper this wave, the faster that negative bounce is, the better the left ventricle suction, the better the left ventricle relaxation is. Okay? This is a relatively primitive way of doing this. There are more advanced three-dimensional ways of measuring early relaxation with three-dimensional strain, etc., but that's not common practice right now. Right now we're doing this using this 20-year-old technology to measure relaxation. Okay? The deeper this E prime, it's called the E prime with tissue Doppler, the better the left ventricle is at sucking blood out of the pulmonary veins. Okay? With some exceptions. Let's think about the way the left ventricle fills. Let's think about diastole. Diastole has 4 periods: isovolemic relaxation, early diastole, diastasis, and atrial contraction. Let me orient you to this Wigger's diagram. This is your aortic waveform. This is your left ventricle waveform. This is your left atrial waveform, AXVY. We'll talk more about AXVY here in a second. Systole and diastole. And this is your mitral inflow, which is your E and your A. So right after the aortic valve closes, diastole begins. You have a period of isovolemic relaxation, where the ventricle is starting to suck, but there's no change in volume. Okay? And then filling begins with early diastole. What was this E named for? Early. E for early. Okay? And then you have a period of diastasis. Where's my cursor? Here it is. Diastasis, no flow. Typically there's no flow during diastasis. If you do have flow during here, that's indicative of high filling pressures. And then you have your atrial contraction, your A wave. A for atrial contraction and late diastole. These are the 4 periods of diastole. 2/3 to 3/4 of blood enters the left ventricle during early diastole, and the remainder enters the heart in late diastole with atrial contraction. Okay? So let's try to put this all together and try to think about how we grade diastolic function. So this is normal. This is your left ventricle waveform. This is your left atrial waveform, all right? This gradient that occurs in early and late diastole gives you your your E and your A waves on your mitral inflow. And this is your tissue Doppler, the E prime. E and E prime are occurring about the same time, right? This is normal. You have an E that is higher than your A. First thing that goes in the left ventricle is its ability to suck blood. The first thing that goes in the left ventricle when it gets sick is your relaxation. First thing to go is your relaxation. So here you have E, A reversal. Now your E is smaller than your A. And your E prime, the indicator of relaxation, the indicator of the bounce that we were talking about, has come down. For the most part, left atrial pressure is usually normal. It can be elevated in this circumstance. With progression of diastolic heart failure or diastolic dysfunction, or with a bolus of fluid, you may get pseudonormal. Pseudonormal because this looks like this. Your E is now taller than your A. You have, again, a restored gradient between your left atrium and left ventricle in early diastole, but your tissue Doppler is still crappy. And here what's going on, instead of the left ventricle sucking blood out of the pulmonary veins and left atrium, your left atrium is pushing blood into the left ventricle with higher pressures. Okay? Here the left ventricle is relaxing well. Here, filling is reliant on high left atrial pressure, pushing blood into the left ventricle. All right? As things get worse, you have a higher gradient, higher left atrial pressure. See the red going higher than it is down here. You have a tall E, smaller E prime, and now your E is more than double your A. Now your E is more than double your A, and this is restrictive filling pattern. This is restrictive filling pattern. I'll tell you something interesting. Young children and trained athletes can have a restrictive filling pattern. If you look at echoes on children and young adults, you'll see, oh, this patient has a restrictive filling pattern. But that's because their E prime, their suction is so good, they have so much bounce in their heart that they're filling the heart almost completely with relaxation. And the atrial component is almost irrelevant. Okay? These patients have excellent, see this negative pressure generated by the ventricle? Excellent suction from their left ventricle. What's important to note is that these things are mostly dynamic. So once you lose your suction, it is rare that it comes back, unless you have an easily reversible cause, such as myocarditis. Say you have a biomyocarditis, you have impaired relaxation, the myocarditis resolves without scarring, you may return to normal function, normal diastolic function. But say you have an infarct, and you lose the suction of your left ventricle, you lose the relaxation, that ain't coming back. Impaired relaxation is as good as it gets. Okay? So for the most part, once you cross from here to here, you're stuck here, and this is as good as it gets. Okay? If you give this person a 2-liter fluid bolus, you may get pseudonormal. You give them Lasix, they come back to here. If you give them a 10-liter fluid bolus, they may get here. You give them more Lasix, they may come down all the way back to here. Okay? What is the auscultatory sound you hear with ischemia? S4, fourth heart sound. Fourth heart sound, and they love to ask this on the boards. There'll be a long stem, someone with having chest pain, etc., and they'll throw in an S4. That is indicative of ischemia. Okay? So this person is walking around, they're doing fine, they occlude a coronary, and this tall A wave gives you the S4. Okay? That's the pathophysiology for the fourth heart sound. Okay? So, between here and here, it's back and forth depending on volume status. Between here and here, it can be back and forth depending on volume status. But there is a stage of no return. People with end-stage cardiomyopathy, people with severe heart failure can develop a permanent restrictive filling pattern. The heart failure service is full of patients who look like this, who have permanent restrictive filling pattern, who cannot, even with Lasix, even with milrinone, even with everything, improve their, go back on the spectrum of diastolic function. Okay? All this is pretty clear? Notice the tall E wave, the tall E wave. This is the pathophysiology for the third heart sound. This is why young children and pregnant women who have very good suction, very good relaxation can develop an S3. And this is why people with heart failure can develop an S3. Okay? There's other tips that you can use to help evaluate your diastolic function. And that is your left atrial size. Okay? If you see normal left atrial size, then things are probably okay. If you see a dilated left atrium, then things are probably not okay. The caveat to that is athletic heart. Some of the athletes that we see, they can have big left atria with a restrictive filling pattern, but an excellent looking heart with an E prime in the 20s. Okay? Some athletes can do that, and that can be sometimes a little bit confusing. But for the most part, for the rest of us mere mortals, if you see a big left atrium, that is usually bad. If you see a small left atrium, that is usually good. Pulmonary pressures, we said, are a reflection of your left atrial pressure. So if your left atrial pressure is high, your pulmonary pressures are going to be high. If your left atrial pressure is low, your pulmonary pressures are probably going to be low, unless, of course, you have a pulmonary vascular process going on. The most common cause of pulmonary hypertension is high left atrial pressure from heart failure, right? Whether it's systolic or diastolic. So let's think about this. We have 3 patients, patient 1, patient 2, and patient 3. Which patient has heart failure? This patient has an ejection fraction of 50%. This patient has an ejection fraction of 65%. And this patient has an ejection fraction of 60%. Well, you're going to interrupt me. Dr. Jokhadar, come on. Heart failure is a clinical diagnosis. You can't diagnose heart failure with echo. No, but you can guess. All right? So let's get more information. What do you think of these walls? They're thick. So if this person had a normal diastolic inflow, would you believe it? No. If you see a normal mitral inflow in a normal appearing heart, it's probably normal. If you see a normal mitral inflow in an abnormal heart, whether there's hypertrophy or dilation of the left ventricle or systolic dysfunction or a big left atrium, high pulmonary pressures, then you can bet the barn that it's probably pseudonormal filling. Okay? So a normal filling pattern in a normal heart, probably normal. A normal filling pattern in an abnormal heart, probably pseudonormal. Okay? So, this person you can bet has abnormal diastolic function, right? Okay. This person here is a normal ejection fraction. This left atrium is huge. So let's get more information on these two patients, okay? This is again patient 1, patient 2, and patient 3. Patient 1 is the one that looked pretty normal. Patient 2 is the one with a thick ventricle, and patient 3 is the one with a massive left atrium. Look at here, E, A, nice, tissue Doppler, E prime of 20. Normal, I mean obviously the grades for normal, the cutoffs for normal depend on your age. For the most part, low teens is normal, for the most part, okay? For the most part. If you see a 20-year-old with an E prime of 10, that's not normal. You probably expect it to be 15. But an easy number to remember is 11. If you look at the ASC guidelines, they simplify it, dumb it down to 11. So, but you got to use various cutoffs depending on the age and the clinical status of the patient. But in this young person, see all that bounce in the left ventricle and the annulus, see all that bounce? You can predict that their E prime is good, and sure enough, here it is. If you look here, there's not much bounce at all. And they have, not so awesome, here's the E prime, here's the A prime. Not so awesome E prime, and they have impaired relaxation, EA reversal. Here you have a tall, skinny E wave, an almost absent tissue Doppler, massive left atrium. This patient has restrictive filling. Okay? Which patient has heart failure? Probably this guy. Probably. Could this person have heart failure? They could. That'd be a clinical diagnosis. What would be your best guess about their filling pressures? This is a tough one. Normal or high? This is a tough one. Left atrial size is normal. I will say when you have an E that is greater than 50 centimeters per second, the left atrial pressures might be high. Okay? The other thing to look at is whether or not this meets the zero line. If pressure is equalized and you have a period of diastasis, then that favors normal filling pressures. But we won't go into that in too much depth. Basically, I just want to give you an introduction today to diastolic function. So heart failure is present when the heart is unable to pump enough blood to keep up with the demands of the body without increasing filling pressures. And the gold-plated standard for filling pressures is the LVEDP, left atrial pressure and LVEDP. That's gold-plated because it's not just one number. I think it's a number of things to look at. But patients who have diastolic heart failure have normal cardiac output for the most part. Okay? But they can't maintain their cardiac output without having high left atrial pressure, without having pulmonary congestion. So heart failure can be present even when cardiac output is normal or high. People who have liver disease, people who have a high output state from cirrhosis, they can have almost universally diastolic dysfunction. Almost universally have high left atrial sizes and even high left atrial pressures. Something to keep in mind. So a few pearls to think about when you're thinking about diastology. The normal early diastolic filling is due to ventricular suction. The first thing that goes in the left ventricle is its ability to relax, its ability to suck blood out of the lungs. Whereas late diastole is influenced by the compliance, the stretchiness, the opposite of stiffness. So if you think about the left ventricle, systole, diastole, okay? And then if there's extra room, it can stretch out and accommodate more fluid. So a stiff heart has lost both relaxation and its ability to accommodate more filling. I think I've lost you there. All right? So when somebody says diastolic dysfunction is a stiff heart, that's only a half-truth, okay? Diastolic dysfunction is two components. The ability of the heart to suck blood out of the lungs, which is relaxation, and that's early diastole. Late diastole is related to the stiffness of the heart or its ability to accommodate, stretch to fill more fluid more filling, and that's compliance. Okay, relaxation, early diastole, compliance, late diastole. In the absence of mitral valve disease, if you have a big left atrium, you can bet that the patient probably has diastolic dysfunction. And the most common cause of pulmonary hypertension is a high left atrial pressure, whether it's from mitral valve disease, systolic dysfunction, or diastolic dysfunction. What about treatment? We have no treatments to improve relaxation. We have no lusitropic agents. Lusitropic are medicines that improve the relaxation. Now, adrenaline does that. So if you look at patients who come in with a subarachnoid hemorrhage, their tissue Doppler can actually be pretty normal just because of all the adrenaline that is circulating in their body, improving their relaxation. Pregnancy has some lusitropic agents that circulate and improve early relaxation, and that's a chemical called relaxin. There were some clinical trials investigating this. I don't think it's panned out yet. We'll see. The treatment for diastolic heart failure is twofold: treating blood pressure and treating congestion. Now, if you look carefully at the literature, there's a bajillion little articles, little trials showing modest benefit to irbesartan or candesartan or spironolactone, enalapril, prendilapril, blah, blah, blah. Hydrochlorothiazide. It doesn't really matter. All you're doing is you're treating the comorbid condition. You're treating the hypertension. Patients who have diastolic dysfunction do not tolerate hypertension very well. People who have diastolic heart failure, if you treat their hypertension, you can improve their symptoms. You have to be careful about using nitrates, though. You have to be careful about using nitrates. If you venodilate, reduce their preload too much and they're preload dependent, they may not like it. Now, obviously, you got to balance that out with coronary disease, etc. But these are some things to contemplate. There is no magic bullet to improve relaxation. We don't have a lusitropic agent yet. And you treat congestion with sodium restriction and diuretics. Atrial fibrillation therapy, depending on the situation and depending on their mitral inflow pattern, you may decide to be aggressive with rate control or aggressive with rhythm control. If someone feels awful when they're in AFib, what did we say the mitral inflow looked like? Probably impaired relaxation. They're reliant on their atrial kick. That's a person you may really try harder to rhythm control. Or if somebody has advanced diastolic dysfunction, a restrictive filling pattern with high filling pressures, then you're probably fine just rate controlling them with anticoagulation, obviously. And obviously, ischemia can worsen diastolic function, so if someone has advanced diastolic dysfunction, that may be a reason to do an ischemic workup. You guys want to, have I given you information overload? Do you want to talk about pulmonary vein inflow? Pulmonary vein inflow? Okay, all right. So this is the Wiggers diagram. This is sort of puts it all together. And we're going to talk a little bit about the pulmonary veins, okay? And what I want you to remember about the pulmonary veins is that your D wave is your E wave. Your D wave is your E wave. Your D wave on your pulmonary vein is the same exact intracardiac activity as your early mitral inflow. They are occurring simultaneously, which is also the same as your, this doesn't project very well, as your Y descent on your left atrial pressure. They love to ask about this stuff on the echo boards. They love to ask this stuff about the echo boards. The correlation between pressure and Doppler and how that relates to the cardiac cycle. So let's orient you. Let's start from the top. So here's a myocyte, action potential for a myocyte. Here's your sarcomeric contractions. And systole, Where'd the EKG go? Yeah, there it is. Your systole on your EKG is your QT interval. Okay? Systole on your EKG is your QT interval, which roughly corresponds to S1, mitral valve closure, and S2, aortic valve closure. Obviously, the ejection sound, ejection click comes from aortic valve opening, and the opening snap comes from the mitral valve opening. Just as an aside, a tangent. Opening snap, is it earlier? With severe mitral stenosis, help me remember. Is earlier or later more severe? Earlier, because your left atrial pressure, this purple, is higher. And if your left atrial pressure is higher, you have more severe mitral stenosis, and your opening snap is going to occur earlier in diastole. All right? Oh. We talked about E and A, and then we got to talk about where these waves come from, the S, the D, and the A. Let's spend a few minutes talking about this. So if you look at your right atrial pressure and your left atrial pressure, they are very similar. A, X, V, Y. A, X, V, Y. A is atrial contraction. X is atrial relaxation. Just as the ventricle sucks blood, so do the atria. Atrial relaxation. V is atrial filling, and Y is atrial emptying. Contraction, relaxation, filling, emptying. Okay? And if you notice, atrial emptying corresponds to the D wave or your E wave, which is when the ventricle fills. So atrial emptying, the Y wave, is the same as your ventricular filling in early diastole, your E wave, and also your D wave on your pulmonary vein Doppler. So your pulmonary vein Doppler, you have your A reversal, which corresponds to your A wave. You have your systolic wave, which occurs during the X descent. The V wave is not usually seen here unless you have severe MR, and then you'll have systolic reversal. All right? A tall V wave from severe MR, say, in the left atrium, is you have an absent S and everything goes south. And that's basically the same thing as your V wave. And your D wave is the same as your Y descent. S during systole, D during diastole. Have velocity yet? Or we're good? We're good. Who's taking echo boards? All right. 3 people are taking echo boards. If you did simultaneous pulmonary vein, Doppler, and left atrial pressure waveform, simultaneous. The black is pulmonary vein Doppler, S, D, Y, S, D, Y, and your red is your pressure. You see how they sort of correspond. But if you were just to reverse it, if you were to invert it, you would see what I'm talking about. The Y is your D, your A reversal is your A wave, your S is your X wave, and your V wave is usually absent in the pulmonary vein, but if you have systolic reversal from a tall V wave from severe mitral regurgitation, for instance, then you would see that. Similar in the right atrium or the superior vena cava. Very similar. And we won't talk about hepatic vein Doppler today. We can afterwards if you guys like, but in the interest of time, maybe we'll talk about constriction, restriction, hepatic vein Doppler in the future. This is something that I really enjoy. So let's try to put this all together. Okay? Here's normal, impaired relaxation, pseudonormal, and restrictive. Restrictive grade 3 and 4. 3, where it's reversible restrictive, and 4, where it is irreversible restrictive. All right? normal EA, nice tissue Doppler, normal left atrium, and your pulmonary pressures are normal. Your S may be a little bit higher than your D, but they should be about the same. They should be about the same. When you have impaired relaxation, and the first thing that goes is the relaxation of the left ventricle, your E wave gets small. If you have a small E wave, your D wave is also small. If your D wave is small, your S is going to be high on pulmonary vein Doppler. Okay? So sometimes when we're doing TEEs and we take a pulmonary vein sample, I'll quiz you based on your pulmonary vein to see if you can predict what the mitral inflow looks like. And it's pretty easy. If you have a tall D, you have a tall E. If you have a small D, you have a small E. So it's pretty easy to sort of think about that. And they love to ask about this on the boards too. They love to ask about correlation between pulmonary vein and what the mitral inflow looks like too, for the echo boards, not for the general cardiology boards. With impaired relaxation, your left atrium is usually normal but sometimes dilated, and your pulmonary pressures are usually normal unless your left atrial pressure is high. Sometimes, if your E wave is tall, particularly above 50, or if your E to E prime ratio, we didn't talk about that much, but there are ways to sort of guesstimate your left atrial pressure using E to E prime. Sometimes your left atrial pressure can be elevated, but it's usually low, usually. As diastolic function worsens, the left atrial pressure goes up, you have a pseudo-normal filling pattern, your tissue Doppler is worse, you have blunting of your S and taller D, your left atrium is dilated and your pulmonary pressures are high. And as things further get worse and your left atrial pressure is even higher, you have a taller E, your E to A ratio is now greater than 2, and your S is further blunted with a taller D, and your tissue Doppler is even worse. Left atrium is more dilated and pulmonary pressures are even higher. Does all this make sense? We talked briefly about the left atrium, and this is an important point to bring up as we close. We know that the bigger the left atrial volume index, the worse the survival. We said the left atrial volume index, the left atrial size, is really like your hemoglobin A1C of the heart. The more poorly controlled the heart failure, whether systolic or diastolic, the higher the left atrium is, the bigger the left atrium is going to be, and the worse your prognosis. So here's 2-year mortality. Here's if you have a tiny left atrium, and here's if you have a big left atrium. And look at if you have a left atrial volume index, and these all comers in this study here, then your 2-year mortality was 50%. That's pretty impressive. There are multiple ways of measuring left atrium. Left atrial area, the 2D measurement that you get on the parasternal long axis, but the preferred way that the American Society of Echo is the left atrial volume index. And you guys will have these slides to sort of figure that out. You get a 4-chamber and a 2-chamber, and you apply this formula to get and the computer, you won't be required to memorize this formula. And the cutoffs are changing. Before it was anything less than 28 was normal, and anything greater than 40 was severe. The new statement, I think, is going to have very different cutoffs. So as we close, take-home points. Heart failure is not just about EF. EF, SHMEF. That's blasphemy, isn't it, for a cardiologist? Diastolic dysfunction clues. Always look at your pulmonary pressures and your left atrial size. When you're reading echoes, a lot of patients just don't fit in a nice category. Impaired relaxation, pseudonormal, or restrictive. And you have to use multiple modalities to try to make your best judgment as what's going on. and also try to make your best guess as to what the filling pressures are. Relaxation means suction, and that occurs in early diastole, and compliance and stiffness are functions of late diastole. And in normal diastole, cardiac chambers fill at low pressures in a short, efficient period of time. I'll leave you with my good old pal Machiavelli, my buddy. In the beginning of the malady, it is easy to treat but difficult to detect. But in the course of time, not having been either detected or treated, in the beginning it becomes easy to detect but difficult to treat. Now, Machiavelli was talking about political insurgencies. He wasn't talking about diastolic dysfunction. This is from his book, The Prince. But I think it's important to recognize when somebody has early diastolic dysfunction. When you see somebody with early diastolic dysfunction who may be asymptomatic, you need to be aggressive with their risk factors. You're not going to change their relaxation, but you can prevent the heart from scarring down and getting stiff. And if you can prevent that, prevent congestion, prevent the left atrium from enlarging, then you may prevent the onset of diastolic heart failure and mortality. So pay attention to early diastolic dysfunction and be aggressive with risk factor modification. Thanks. Any questions?
I met one of your patients who works at Atrial. Guy with Shone's syndrome.
Yeah.